Great, thanks. So I get the opportunity to kind of wrap this up, the content with discussion about survivorship. So if you give me my next slide, I can start off. I wanted to start off by speaking about one of my favorite patients. This is a patient that got Hodgkin's disease, which is a type of lymphatic cancer, and was treated in the early 1990s. His treatment consisted of splenectomy, a lot of radiation, 8 different chemotherapy drugs, and at the time, in the 90s, the supportive care given to patients was very different than what we're able to do now. Fortunately, this patient was able to survive his cancer and is now well known to our community in San Antonio in our division in HEMONC. If you go to the next slide, over the course of this patient's time as a survivor, which is about approximately 30 years, unfortunately, he has experienced some health problems that were the direct result of the cancer treatments that saved his life. And so kind of in chronological order, these include things such as hypothyroidism, which is caused by radiation to the neck, pulmonary fibrosis, which is scarring of the lungs caused by radiation, and one of the drugs we commonly give for Hodgkin's disease, bleomycin. There's issues with infertility. In his 30s, the patient developed a scarred aortic valve and had to have it replaced surgically, and workup for the surgery was found to have 3 coronary vessels that were all greater than 95% blocked. So at the same time, got a 3-vessel coronary bypass. The patient has had more recently, some skin cancers in the radiation field removed, had a small TAA or stroke, which left no lasting deficits, fortunately, and then developed diabetes, likely secondary to either the chemotherapy, but more likely radiation to the abdomen, which affects the pancreas. And so this is my favorite patient, if you go to the next slide, because that's my story. I'm the patient. I had Hodgkin's disease as a teenager when I was 16 years old, was fortunate to survive. The experience really, I think, catapulted me into the world of medicine. I grew up on a farm in Eastern Washington. My mother is a teacher. I was really never considered becoming a doctor or physician until I went through that experience. I was really interested in science before that, so I think it was kind of a natural progression because of my academic interests before I experienced being a patient. But I think what came after that was not expected, and it's something we've learned a lot about in pediatric oncology in the 21st century. So next slide. What I always stress is that my story as a survivor is not unique. If you look at the data from the big epidemiologic studies of survivors that have been completed to date, the vast majority of them will have some type of health problem related to their previous cancer treatments. In some respects, this is a very good problem. Dr. Longeman touched on this about what it's taken in terms of our field to get to the point where we have patients that survive that long. And I think that is one of the things that drew me into the field of pediatric oncology, was just feeling like I wanted to be a part of that because I'd benefited from it. But then just the collaborative nature of how our field works to move things forward. And pediatric oncology it has really been successful in that realm, in those aspects. If you think about it, in the history of oncology, some of the first treatments done with chemotherapy were conducted in children by Sidney Farber up in Boston. The concept of combination chemotherapy was developed by M.L. Fry and M.L. Fry-Reich in children. And then I think some of the really early data on these long-term outcomes also came from pediatric cohorts. So I think it's just a very collaborative field. And what we've got out of that is where we're at now. In the 21st century, we have 5-year survival rates for all newly diagnosed patients are greater than 75%. Unfortunately, cancer still remains the #1 cause of death by disease for children in the United States. So what this means is we have kind of a dual problem going forward. One is to continue the type of work that Dr. Langevin described in providing basic science research that gives us new compounds and drugs to test in the clinic via those wide kind of collaborative clinical trials across the country and through cooperative groups. But then also now we have this problem with survivorship. So we have, at current time, we have about 500,000 long-term survivors of pediatric cancer in the US. Worldwide, this number is going to only increase as some of our ability to bring the more Western approach to pediatric cancer gets in across the world, and there's big efforts ongoing right now to do that. The number of survivors is going to increase across the world because of that. And this isn't just a problem limited to pediatric cancer patients. It's actually a huge number of cancers of all ages. And so a lot of what we study in terms of the pediatric cancer survivor population is also relevant to adult people that get cancer and then survive. And so by 2026, in the United States alone, we're projected to have about 20 million survivors in this country. So there's a really, it's a new problem. It's a good problem because we're saving people, but we need to start to help them be healthy. Next slide, please. And so what do we do? So our goals for follow-up care is in our survivorship program are many. One is to recognize that the health risks that these survivors face are numerous. As survivors grow up in age, the risk of relapse disease is not the primary health concern. So as they get past 5 years and older, the rate of death from their primary cancer gradually goes down, and the rate of other health problems, cardiovascular, pulmonary, etc., go up. And at about 15 years post diagnosis of their cancer, the rate of mortality from non-cancer causes actually exceeds cancer causes. And so this is something that has to be thought of when you're dealing with patients that hopefully are going to live 3, 4, 5 decades post our curative therapies. One of our main jobs in our survivorship program is to coordinate care between pediatric oncologists, bridging the gap to multidisciplinary survivorship programs, and primary care specialists and adult specialists. So that's something that's one of the more intractable and difficult problems to solve in survivorship, but one that we're very involved and interested in solving as our cohort ages, and we need to continue providing comprehensive care to them. And then finally, this is probably one of the most important things, is we need to educate our population about these risks, and we need to educate the providers that they're going to come into contact on these screening recommendations. And one way we do this is by, oh, sorry, hit the next slide. I was hitting my, like I had control of it, is by disseminating expert consensus screening follow-up guidelines that are produced by a panel of survivorship experts from the Children's Oncology Group. And so we do this, provide this information to our patients in face-to-face clinic visits. Now they have the ability, patients individually, to get this information via a web portal called Passport for Care, which we try to sign up all our patients into. And then these guidelines are available at www.survivorshipguidelines.org for any provider that can access that website. Because of that, anybody can get the access to the guidelines and then provide care to a patient they're seeing. Next slide. So my final slide, I have a quote from Albert Einstein, and it's this: problems cannot be solved with the same mindset that created them. So the reason that we have this problem of survivorship is that there was a particular mindset of how we're going to cure childhood cancer that was implemented, and then it's gotten us to this 80% survival rate. Going forward, I mean, that's a tremendous accomplishment. Sorry if my dogs are barking. Going forward, the mindset that we have to take is going to be different to deal with the survivorship issue. And so research is actually a really critical way in which we're going to address these problems. So it's an important endeavor that will facilitate improved long-term outcomes for pediatric cancer survivors. And some of the examples of how research can impact this population are developing preclinical research to understand disease-causing mechanisms and test novel interventions. So understanding how radiation damages the pancreas or how particular chemotherapy agents damage the heart will allow us to develop potentially new interventions that we can test in mouse models or animal models that may one day get to be used in our patients. Secondarily, we can do clinical studies to evaluate risk and identify new areas for needed intervention. So we're learning a lot about our population as they progress up in age after becoming survivors, and undoubtedly we're going to identify new areas that we didn't previously recognize. And another way of thinking about this, we're always coming up with new medicines that we're testing. Those medicines may have late effects that we're going to have to deal with. And so identifying those and then coming up with interventions so that we can mitigate those is really important. And then finally, how do you actually put this into practice? You do an intervention study where you have a randomized control trial. And there's a few examples of these that are ongoing right now across the country. One is testing a medicine that lowers blood pressure as a way to reverse the heart damage that's caused by one of our medicines. And so that's ongoing. But there's really a push by the National Cancer Institute and the Office of Cancer Survivorship there to promote intervention studies. And so as we look at this collectively, we need to have preclinical research to identify opportunities for interventions, clinical research that identifies problems that need to be intervened upon, and then we actually have to carry those out in patients in randomized control trials. The end sum of that will be patients that not only survive their cancer, but they do so in a way that they thrive without the tremendous health burden of late effects that we see in a lot of our patients right now.